Hello, diagnosis and treatment planning class. I am going to cover somatic symptoms and related disorders. So just a second, I'm going to go ahead and share my screen with you. Hope everyone's doing well. Okay. So somatic symptom and related disorders include somatic symptom disorder, illness anxiety disorder, conversion disorder, psychological factors affecting other medical conditions. Oh, I'm not going to cover that one actually. And factitious disorder, other specified somatic symptom and related disorder, and unspecified somatic symptom related disorder. Okay. So some terms. So somatic relates to the body, especially as distinct from the mind. So individuals experiencing somatic symptom-related disorders will experience something in the body. And a symptom is a sign of the existence of something, especially an undesirable situation. And a disorder is a disruption of normality. So somatic disorders share the existence of somatic symptoms, pain, fatigue, uncomfortable feeling, possibly, loss of function of your sight or being able to walk, something like that. And it's associated with clinical amounts of stress about those symptoms. So not only is someone feeling pain or feeling some sort of symptom related to the body, they're also very distressed about it. So it's a combination of somatic symptoms and distress about those symptoms. So the criteria is one or more somatic, so this is somatic symptom disorder. One or more somatic symptoms or associated health concerns as manifested by at least one of the following. Disproportionate, so they have to have either pain or loss of function or discomfort and some sort of symptom related to the body. And they also have to have disproportionate persistent thoughts about the symptoms. They need to have high anxiety about the symptoms, and the health concerns have become a focal point in their life. And you would specify if it's a persistent, which would be longer than 6 months. So somatic symptom disorder has to exist for about 6 months. But if it's longer than that, you would specify persistent, and you would specify if it's with predominant pain and with current severity, mild, moderate, or severe. And of course, that's all spelled out in your DSM. And so you want to make sure that this is not accounted for by another diagnosis. So that's when we look at our differential diagnosis. So some things it could be other than somatic symptom disorder is panic disorder. So sometimes people will experience, shakiness, nervousness, heart palpitations. These are physical somatic symptoms, but they typically occur in an acute episode, like an actual panic attack. So if it's not a full-on panic attack and it's kind of happening all the time, you can rule out panic disorder. Generalized anxiety disorder. So generalized anxiety disorder is really when someone's worried about everything. They're worried about their job, they're worried about their relationship, they're worried about their health, they're worried about their sleep patterns, and their sleep may be affected. But they're really worried about all the things, not just the somatic symptoms. It could be illness anxiety disorder, which we're about to cover, and that's minimal somatic symptoms. They're having less of the physical symptoms and more of the fear that they have a serious illness or disease. So that's the hypochondriac. And then conversion disorder. So conversion disorder is a loss of function that can't be explained by medical evaluation. So maybe they're unable to walk, or they can't see anymore, or they have some sort of neurological condition that is not explained by medicine. And then body dysmorphic disorder, preoccupied by fear on of appearance. So they're not worried about an illness or the symptoms, somatic symptoms, so much as they're worried about the appearance of their body. So that's how you can rule that one out. And then OCD is obviously characterized by repetitive behavior. So, counting things, repeating things, engaging in rituals, that sort of thing. The next disorder I'm going to cover is illness anxiety disorder, or hypochondriasis. And that is a preoccupation with having or acquiring a serious illness. So it is similar to the previous somatic symptom disorder, but there's, again, less of a focus on the somatic symptoms. So the somatic symptoms are not present, or if they're present, they're only mild in intensity. But there is a high level of anxiety about health. They're easily alarmed about personal health status, and they perform excessive health-related behaviors. And the illness preoccupation has been present for at least 6 months. The illness-related preoccupation is not better explained by another mental disorder. So you want to specify if it is the care-seeking type. So medical care is included, including physician visits or undergoing tests and procedures, or the care avoidant type. Medical care is rarely used. So differential diagnosis, you can rule out a few different things. Somatic symptom disorder, because the somatic symptoms would be present. So again, if it's accompanied by pain or some other physical ailment, then it would not be this, and you would want to look at somatic symptom disorder. Anxiety disorder. So anxiety is very acute and episodic. So you want to rule that out. The anxiety would be about anything and everything, generalized anxiety disorder or panic disorder. It wouldn't have a specific fear of the illness. And OCD, so not focused on fears of getting a disease. So OCD could be related to other things, but not related to getting a disease. Or psychotic disorder. So there's no delusion on the IAD. Okay, so conversion disorder is a little bit different. Conversion disorder is the dramatic loss of functioning, which can appear to be a serious neurological condition. And it involves the sudden dramatic loss of neurological function, either motor, so paralysis, or sensory, hearing or vision, but there's no medical cause. So Freud noted that symptoms of people who were experiencing conversion disorder had obvious and symbolic significance associated with a particular stressful life event. So maybe the ailment connects to some sort of life event. But yeah, there's actual decline in function and an inability to function, but there's no neurological cause. That's conversion disorder. So in conversion disorder, the key criteria are one or more symptoms of altered voluntary motor or sensory function. Clinical findings provide evidence of incompatibility between the symptom and recognized neurological or medical conditions, and the symptom or deficit is not better explained by another medical or mental disorder. And the symptom or deficit causes clinically significant distress or impairment in social, occupational, or other important areas of functioning, or warrants medical evaluation. So again, differential diagnosis, you're going to want to look for somatic symptom disorder, factitious disorder. So the difference between conversion disorder and factitious disorder is that the illness with factitious disorder, the illness is intentionally produced. So in conversion disorder, the person truly cannot function or believes they cannot function. Whereas in factitious disorder, there is an intent to deceive. Body dysmorphic disorder, obviously there would need to be preoccupied by fear of on appearance. Depressive disorder, a presence of depressive symptoms. Neurological diseases, so neurological diseases that could explain the symptoms. So so obviously you'd want to rule out any medical diagnosis that actually could account for the neurological disease. Sometimes it can take a little while for someone to figure out what fits. And then panic disorder. So it could be a panic attack mimicking a neurological disorder. So sometimes people get heart palpitations. They get, they start to shake. Maybe they're frozen. They can't feel like they can't breathe. They can't calm down. That could mimic conversion disorder. But of course, panic disorder is a panic attack will come and go. And on to factitious disorder. So factitious disorder is a form of mental illness where an individual will deliberately produce or exaggerate symptoms in order to gain sympathy and attention. So while the others are characterized by, in somatic symptom disorder, there's some sort of pain or physical discomfort that is very real to the client. With conversion disorder, they're experiencing a loss of function, whether that be rooted in psychological issues or not. They are experiencing a loss of function, and they truly believe that what's happening to them is real and what's happening to them is true. In factitious disorder, it's the person is intentionally trying to deceive the mental health care worker or the medical doctor. So the person deliberately produces or exaggerates symptoms in order to gain sympathy and attention. And it can be imposed on self or it can be imposed on another. So the person presents as ill or injured or induces injury or disease with identified deception. The illness or injury is evident even in the absence of external rewards. It's not explained by delusional disorder or psychotic disorder either, where again, in delusional disorder or psychotic disorder, the person would actually believe that they're experiencing the symptoms that they're experiencing. And again, we mentioned the same thing with somatic symptom disorder, and conversion disorder, that they truly believe that something's wrong with them. So yeah, and then it's you want to specify if it's a single episode or recurrent episode, 2 or more events of falsification of illness or induction of injury. So some people will actually induce an illness or injury just to gain sympathy or attention. And then you want to specify if it's imposed on another or by proxy. So typically a person would bring in their child or maybe a dependent adult, and they would present them as ill, injured, etc. And that's usually to elicit sympathy, and the behavior is evident without obvious external rewards. So that's the thing about factitious disorder, is that there's no, actual financial reward like in malingering. Malingering, there's a purpose and there's a reason why someone might be making up an illness or an injury, and that could be for financial reward or some other tangible gain. Whereas with factitious disorder, there's no tangible reward. It's just psychological needs being met, I guess, through the disorder. And of course, if you're going to diagnose factitious disorder by proxy or imposed on another, you're going to diagnose the perpetrator, not the person who's presented as ill, like the dependent adult or child. So if you're going to make sure you've got the correct diagnosis, you always look at differential diagnoses. So somatic symptom disorder versus factitious disorder. So in somatic symptom disorder, there may be excessive attention and treatment seeking for the perceived medical concerns, but there's no evidence that the individual is behaving deceptively. Again, with somatic symptom disorder, the person truly believes there's something wrong with them, even if there's not a medical reason for the somatic symptoms that they're having. And then with malingering versus factitious disorder, with malingering, there's an intentional reporting of the symptoms for personal gain, money, time off, work, etc. But in factitious disorder, it requires the absence of obvious reward. And conversion disorder versus factitious disorder. Conversion disorder is characterized by neurologic symptoms that can't be explained by medical evaluation. And factitious disorder is distinguished from conversion disorder by the evidence of deceptive falsification of symptoms. And then one more diagnosis that it could be is borderline personality disorder. And in borderline personality disorder, there's a deliberate physical self-harm can occur in association with other mental disorders. But in factitious disorder, the induction of injury occurred is in association with deception or to show others that the person is sick. In borderline personality disorder, the self-injury or harm is related to the borderline personality disorder, but not directly connected to the illness that they're, that it would be connected to in factitious disorder, if that makes sense. Okay, one more thing. Okay. So malingering is not in here, but malingering, so it's not in the DSM-5, but just know that that is when someone is just intentionally making things up, but you would not necessarily give them a diagnosis. Other specified somatic symptom and related disorders. Brief somatic symptom disorder can occur, and this is when someone has the somatic symptom disorder criteria, but they don't meet the duration of 6 months of symptoms. Brief illness anxiety disorder. Again, the duration of symptoms is less than 6 months. Illness anxiety disorder without excessive health-related behaviors means that criterion D for illness anxiety disorder is not met. And pseudosciasis, I don't know if I'm saying that correctly, but I think it's possible, is a false belief of being pregnant that's associated with objective signs and reported symptoms of pregnancy. So those are the other diagnoses that could be there. You obviously also want to rule out if any of these are occurring due to substance abuse. Yep. And then there's unspecified somatic symptom and related disorder. And that is when there are symptoms that they might meet some of these symptoms, but they don't really meet all of the symptoms to fit into any one criteria or any one disorder. So where does this come from? Why does this happen? Some people who've experienced trauma or violence or abuse or deprivation may engage in some of these behaviors. And it's a learned behavior. So if the client's successful at getting attention from illness, or they've maybe grown up with someone who was seriously ill, they may know that person gets attention and positivity and help and care from others. So that might be a motivating factor that contributes to some of these. And treatment. So medication. So antidepressant and anti-anxiety medications are used to help with these. Family therapy and family support. So teaching family about the needs of the client and about not colluding. So trying to help them get their needs met in different ways and not buying in when they're engaging in behaviors that could lead them down a negative path. Not giving in when they're trying to get attention through illness, sort of illness promoting or seeking behavior in a way. With CBT, you're going to explore irrational thoughts. like identifying and modifying unhelpful beliefs about symptoms and disease. So some psychoeducation can be involved in there, and trying to uncover the reasons for engaging in these, fearful kind of associations. And then behavioral techniques. So they're helpful to alter illness and sick role behaviors and resume engagement in normal activities to promote more effective coping. And then Adlerian would be helping them develop a pro-social behavior to get needs met in a healthier way. Okay. And that's all I have for you there on somatic symptoms and related disorders. I hope you have an understanding of what that means. Just remember, somatic is of the body. So if someone has pain that's unspecified or some neurological issue that can't be explained by medicine, it's possible that they're experiencing one of these disorders. If they're overly fearful of illness, that might be an indication that they have illness anxiety disorder. Obviously conversion disorders connected to a lack of function and neurological ability that can't be explained. And then we have our factitious disorders, where someone is engaging in deceptive behavior to try to gain attention through illness or with themselves or someone else. So we also want to remember that if a parent is intentionally harming a child or making them sick, then we are obviously required to make a report to Child Protective Services to make sure that the child is safe. All right, that's all I have for you. As always, if you have questions, you know where to find me. Have a great evening.